Dr. Choudhury, if you are ready with your presentation, with the approval of the respected panelists and the chairpersons, may we please begin with. Thank you.
Yeah, so I hope I'm audible now. Sorry for the delay. My topic is atrial fibrillation in different phenotypes of heart failure. So thanks to the organizers and respected seniors for giving us this opportunity. Um so as we move along, we know that atrial fibrillation and heart failure are often encountered together, and both of these conditions share many common risk factors such as hypertension, obesity, diabetes, ischemic heart disease, sleep disorder, breathing. And all this together can lead to atrial cardiomyopathy as a consequence of the structural, electrical, and contractile changes that occur in the atria and predispose them to develop atrial fibrillation. So, development of heart failure first, before the development of atrial fibrillation, seems to infer an poorer prognosis as compared to development of atrial fibrillation leading to heart failure or maybe a tachycardiomyopathy. So AF may contribute to the development of heart failure and may further increase or uh, promote the development of symptoms due to a variety of factors. One of it is that the loss of atrial systole, especially in a case of stiff left ventricle, will reduce the ventricular filling and reduce the cardiac output by as large as 25%. And irregularity and high heart rate during AF may increase the likelihood to develop systolic dysfunction. So, and it may also lead to a reversible form of tachycardiomyopathy, which we encounter not that uncommonly. And recovery of LV ejection fraction after restoration of sinus rhythm is evidence to this fact. Now, if we compare atrial fibrillation in HEF-REF versus HEF-PEF, greater eccentric left atrial remodeling is seen in HEF-REF as compared to increased left atrial stiffness as seen in HEF-PEF. AF is more likely to precede heart failure in HEF-PEF, and the common triggers which predispose a patient to developing HEF-PEF as well as atrial fibrillation or myocardial inflammation due to several etiologies and fibrosis, which leads to the increased LV diastolic dysfunction as well as the increased atrial stiffness and fibrosis. So, mortality in HEF-REF is higher in HEF-REF patients who develop new onset AF as compared to HEF-PEF. And pre-existing atrial fibrillation occurring before heart failure is associated less with mortality as the reverse, as compared to the reverse. So, clinical presentation of atrial fibrillation in heart failure. We all know that heart failure is diagnosed mostly clinically with the help of echo findings and biomarkers. And as the symptomatology often overlaps, it becomes often difficult to diagnose HEF-PEF, especially in absence of abnormal ejection fraction, whether the symptoms are due to the atrial fibrillation or due to the heart failure. Now, atrial fibrillation risk factors common in both phenotypes, HEF-REF and HEF-PEF: obesity, sleep disorder, breathing, diabetes, hypertension. Several pathways are suggested. Important ones are atrial fibrosis, infiltration with fat cells, shortening of pulmonary vein effective refractory period, which leads to the predisposition of these patients to develop AF. Now, reduction in AF burden can be achieved by a variety of ways. Now, if the person has obesity, at least a 10% reduction in weight will help in the reduction in AF burden. If the patient has OSA, CPAP therapy will help in reducing the progression of AF to permanent AF and also reduce the recurrence after a successful catheter ablation. Glycemic control will reduce the risk of AF, and as the RACE-3 trial demonstrated that in patients with early persistent AF, if a factor-driven pharmacological and lifestyle intervention is given to control the underlying risk factors, then the AF burden will be much less. Now, what is the basic plan of action in a patient of heart failure with atrial fibrillation? So, step one is assess the comorbidities and address and it with pharmacological and non-pharmacological interventions. Now, step two is initiate medical treatment based on current guidelines. For HEF-REF, we all know that ARNI, beta blockers, MRA, SGLT2 inhibitors, and lifestyle modifications are the key pillars. of the management. And as far as HFPF is concerned, ARNI maybe on the if the EF is on the lower side, but still no recommendation for ARNI, strong recommendation for ARNI. So SE, ARB, MRA, all these are class 2B indications. We can try those things. And recently, over the last 2-3 years, SGLT2 inhibitors have come up with a stronger recommendation for HFpEF patients. Now, if the patient is still symptomatic and has atrial fibrillation, symptomatic atrial fibrillation, so next we have to discuss whether to keep the patient on medical therapy or we should go for catheter ablation. With the recent trials on catheter ablation showing successful results, so they have gained from a weaker class 2B indication to a stronger class 2A indication as far as the ESC atrial fibrillation guidelines of 2020 is concerned. So we can see in the lower panel that in HFpEF and HFpEF, catheter ablation can be a class 2A indication. After failure of drug therapy, it becomes a class 1A indication, and in tachycardiomyopathy, it is a class 1A indication. So we have to discuss these options with the patient and patient party, keeping in consideration the overall risk profile of the patient. So this slide actually summarizes the stepwise approach which we can apply in a patient of AF with heart failure. So as we know, GDMT for heart failure and anticoagulation, in certain subsets of heart failure, whatever be the CHA2DS2VASc score, if there is no significant bleeding risk, we should go for anticoagulation. Otherwise, in stable patients, we can look for the CHA2DS2VASc score. Uh, uh, then in atrial fibrillation management, we will, depending upon the comorbidities and several factors, we will either choose rhythm control if we think that the symptoms is mostly related to the arrhythmia. Then we will go for rhythm control. And otherwise, if we think that the anatomic defect or the structural heart disease is too strong and we cannot achieve a rhythm control, and also if we think that the symptomatology is mostly due to the hemodynamic of the patient rather than the atrial fibrillation, then I think rate control is also a fair option. Now, if we look at the rhythm control, there are two options: pharmacologic rhythm control and by atrial fibrillation ablation. Now, pharmacological rhythm control agents are in HFrEF are dofetilide and amiodarone. Amiodarone being used more commonly by different physicians in different setups. And in HFpEF, the options are more. Sotalol and dronedarone are also the added options. Now, we will look at the rate control separately in details after a few slides. Now, if we look at the rate versus rhythm control data, the earlier studies, when the catheter ablation was not an option, they showed that, apart from one or two studies, they showed that the all-cause mortality or the major endpoints did not vary significantly if we go for rate control or rhythm control. The important studies being the Diamond CHF study, the AFFIRM heart failure subset, which is the data was derived from the AFFIRM registry, the AF CHF study. These showed that uh, the all-cause mortality and hard endpoints were not significantly reduced, whether we go for rhythm control versus rate control. Only for some of the studies showed that rate control is not inferior to rhythm control, and sinus rhythm, that is with rhythm control, may improve quality of life and LV function. So if we look at the box lower down, rhythm control, only 53% of the patients can have recurrence of AF after 1 year, even after initial successful phase. And rate control, 30% of the patient can be back in sinus rhythm. So targeted therapy of underlying condition, as we had already discussed, will give a better result with rhythm control. And among all the drugs available, amiodarone has the best result in maintaining sinus rhythm after 1 year in 58% of the cases. Now, if we look at the pharmacological agents for rhythm control based on different trials like the Todd-Pedersen study, which included dofetilide in symptomatic CHF and severe LV failure, it was effective in converting AF and decrease its recurrence and decrease heart failure hospitalization. The important thing is with dronedarone, the Andromeda study showed that dronedarone was actually associated with increased mortality in HFrEF patients. So it is avoided in those group of patients. So depending on this data, what are the options we have for rhythm control? So for HFpEF patients, additional two agents, sotalol and dronabinol are present. Otherwise, whether be it HFpEF or HFrEF, the common agents are dofetilide and amiodarone. For amiodarone, we all know that apart from the potassium channel, it also inhibits a variety of other channels. So the effect is much more stronger, and it also has a lesser chance of torsades as compared to dofetilide and ibutilide. And however, the side effects are various: pulmonary, hepatic, thyroid, neurological, ocular. Different side effects are there. Uh, and we must avoid other QT prolonging drugs and warfarin when we are using amiodarone, and digoxin when we are using amiodarone. For dofetilide, it is a much more potent agent with more renal metabolism. However, torsades spontaneous is a risk when the therapy is initiated. So, for the first 3 days, patient should be hospitalized. Now, pharmacological agents for rate control. Options for AV nodal blockers to obtain rate control include beta blockers, non-dihydropyridine CCBs like diltiazem, verapamil, and digoxin. Now, diltiazem, verapamil are contraindicated in HFrEF due to the increased chances of mortality. Therefore, beta blocker can be considered as first-line therapy for rate control in these patients. And some analysis like the CHF trial showed that beta blockers are associated with lower mortality in patients of HFrEF with AF. Digoxin is not as effective as beta blockers in heart failure because it has a more vagotonic inhibition of AV nodal conduction. So in resting state it is effective, but in active state when the vagal tone is low and the sympathetic tone is high, the rate control may not be as certain special scenarios cannot be ignored. AF in valvular heart disease with CCF, especially in MS patient mitral stenosis, is very useful. Digoxin still now, and also in associated RV dysfunction, digoxin helps to tide over the difficult period. And also in CCU setup in ADHF patients with AF with fast ventricular rate with a low BP where the other agents cannot be given, IV lanoxin is often helpful and saves the day. So now the target for rate control, what should be the heart rate for rate control? So the post hoc analysis of some trials like the RACE 2 trials, that there is not much difference. The Swedish heart failure registry suggests that HFrEF heart rate greater than 100 should be associated with increased mortality. So if we follow the 2020 ESC guidelines, lenient rate control, that is a heart rate less than 110 or maybe 100 is an acceptable initial approach regardless of the heart failure status. If we go for stringent heart rate control, then the target should be less than 80 at rest and less than 110 with moderate exercise. So strict rate control should be reserved for the patients with tachycardiomyopathy. In patients where we are going for biventricular pacing in order to achieve a higher percentage of biventricular pacing, and patients who are still symptomatic on lenient control. So data on catheter ablation, over the last decade, catheter ablation has come up. If we see that most of the trials have had very small number of patients, even then, the pulmonary vein isolation, catheter ablation of AF with pulmonary vein isolation led to positive results of increased LVEF, increased composite of quality of life and 6-minute walking, those parameters. And the pooled data of these studies, when meta-analysis was done, the overall results were good. Now, if we look at the more recent trials like Castle trial, those were relatively larger trials with over 360 and over 750 patients. And in Castle AF trials with HFrEF patients, EF less than 35, the pulmonary isolation was superior and the result was significant. However, in Cabana HF, though PV was superior, the target was P value was not significant. It is difficult to compare because the Castle AF had mostly HFrEF patients on ICD or CRT. Cabana HF had a various wide spectrum of patients. Only 10% had an EF less than 40. So the risk for primary endpoint was directly related to a low or high AF burden at 6 months, more useful in tachycardiomyopathy if we cut down the AF burden. longer periods of sinus rhythm will actually improve the outcome eventually. And if you look at the PVI techniques, the pulmonary vein isolation is still the cornerstone. However, additional ablation like posterior wall ablation, linear lines of ablation, ablation of complex fractionated atrial electrograms have been tried in different trials. Cryoballoon for PVI approach is being tried in the RES-8 HF and contra HF trials, and PVI with more durable endocardial lesions with high power short duration ablation is being tried. The results are yet to come of these trials, and surgical approach and hybrid approaches are also coming up. So the patient with less severe symptoms and early onset of AF are likely to get benefit, and less favorable for benefits are large atria, highly fibrous atria, and also a trial of cardioversion with amiodarone can be tried before we go for catheter ablation. So, based on this data, the 2020 SCF guidelines gives of first line catheter ablation of AF in HFrEF and HFrEF. AV nodal ablation for definitive.
Dr. Choudhury, we really need to wrap up at this point of time. So, can we please take the discussion forward when we have our dedicated time for question answer segment?
Okay. So I will just end